The brain represents 2% of our body weight, but uses 20% of the energy in our bodies. So of course, if we're having an issue making energy, it's going to exquisitely affect our neurons and our brains.
Hi, Casey.
Hi, Jeff.
Okay, I'm so excited to be here with you and to celebrate your new book. This is right around the corner, Good Energy. And of course, our new Commune course. Oh my God.
Optimizing your metabolism.
Optimizing your metabolism. And that's what we're here to talk about, because there's really very few things as important as doing that, because optimized metabolism, or I should say in this particular case, like not optimal metabolism, bad energy, mitochondrial dysfunction seems to be upstream from virtually all or many of our most serious and widespread chronic conditions. So can you help us explain or can you help us understand why that is?
Absolutely. Yeah, I think it can be somewhat disconcerting or almost seem like fantastical for people to hear that like almost every chronic symptom and condition in the Western world that we're dealing with right now that contribute to well over 80% of our $4.5 trillion healthcare costs are all potentially rooted or accelerated by the exact same thing. But that's exactly what the case is. And it's actually very simple to understand it. Going back to what we talked about in the last episode, every single cell in our body, 40 trillion plus cells, requires cellular energy to do its trillions of chemical reactions every second, which all bubble up into our lives. And if that process of metabolism, if there's mitochondrial dysfunction, if that's not working properly, we have essentially an underpowered cell. It doesn't have enough energy to do its work. And so what happens if you have an underpowered machine? It becomes dysfunctional. And so this core process that's happening in our cells is leading to this fundamental underpowering. But this is the interesting thing. We have over 200 cell types in the body. So we've got retinal cells, and we've got endothelial cells lining our blood vessel, and we've got retinal cone cells, and we've got ovarian theca cells, and we have hepatocytes, and we have intestinal L cells. I mean, we have so many different types of cells. The very cool thing is, of course, they all came from one, and they differentiated into all these different cell types. But underpowering in different cell types can look like different diseases. That doesn't necessarily mean that the diseases are totally different things, but because of our Western reductionist, very fragmented, siloed way of looking at things, we choose to describe those diseases as different things. And there's nothing nefarious about this. I think it's actually just healthcare not catching up. So if you think about it, back in the day when we were naming all these different diseases and categorizing them, we didn't have some of the tools to understand a lot of this invisible internal cellular biology happening, these signaling pathways associated with metabolism. So what did we do? We described diseases the way that we could, which was describing them based on their symptoms. So even now, in the actual definition of like how you diagnose depression, it's characterized by sets of symptoms that you do or do not have. And if you meet those different symptoms, you have the disease. More recently, we have the incredible capability with all the different, fancy tools that we have in scientific research, proteomics and metabolomics and, electron microscopy and just so many aspects of our scientific advancement. We now actually can understand like the invisible workings of cells. But when we described diseases, it was when we could only describe them based on their characteristics. If we were to like classify diseases now for the first time, I think we'd probably describe them based on actually what's going on inside the cell that's leading to the disease. And if we did it on that level, what we'd find is that so many diseases are actually the same thing happening in different cell types. And so this is why when we really look at the research and dig into different conditions, what's the pathophysiology, the true cellular processes leading to the diseases, what you find is that the metabolic spectrum includes depression, anxiety, infertility, erectile dysfunction, gout, migraine, chronic pain, fibromyalgia, all the way to stroke, heart disease, type 2 diabetes, obesity, Alzheimer's, dementia, chronic kidney disease, chronic liver disease, increased propensity to die from influenza, COVID-19, pneumonia. I could literally go on and on.
Pretty
and
good.
In writing this book, I mean, I did dig into all that physiology, and inside the cell, so much of the same stuff is happening, but that's not how we're characterizing diseases because we're still operating in an outdated model.
Wow, Casey, incredible. Yeah, some of these I think are easier to understand for people, like diabetes or type 2 diabetes, which I'm very familiar with. That is a direct result of insulin resistance, for example, and mitochondrial dysfunction and high blood sugar levels, right? So, and then, you see the retinopathy and the neuropathy and all the kind of downstream impacts of, or symptoms or presentations of diabetes. I think it gets a little bit more difficult to untangle when you start to talk about like dementia, for example, or Alzheimer's. But you introduced me to Chris Palmer. We both know Ben Bickman. They have both made very good cases for these diseases, like dementia, being essentially brain energy diseases or deficits.
Mm-hmm.
Can you just pull on that for a moment?
Sure. The brain represents 2% of our body weight, but uses 20% of the energy in our bodies. And so, of course, if we're having an issue making energy, it's going to exquisitely affect our neurons and our brains. And Dr. Chris Palmer, in his incredible groundbreaking book, Good Brain Energy, and then, of course, Dr. Ben Bickman in Why We Get Sick, paints this picture of not only Alzheimer's, dementia, but almost everything across the neurologic spectrum from childhood. So we're talking neurodevelopmental disorders, ADHD, learning issues, to midlife, brain fog, again, ADHD, which is going up, depression, anxiety, and then into older age with neurodegeneration. So from neurodevelopmental to neurodegeneration, in different age groups, we're seeing this issue with powering this complex processing system of the brain showing up in so many different symptoms that are fundamentally rooted in an underpowered system. And where it really related to me, since I trained as an ear, nose, and throat doctor, was so astonishing to me when I looked at the research between insulin resistance and hearing loss. Never in 5 years, I left my residency, but I completed 4 years of my residency. Never in those 4 years did I ever hear that it's possible that hearing loss could be related to insulin resistance or blood sugar problems. But the data is very clear that as metabolic syndrome criteria and insulin resistance goes up, our risk of hearing loss goes up profoundly. And if you think about it, we're talking about hearing. First of all, it's incredibly complex signal processing in the body, very high energy intensive. It's also a very small part of the body. If you think about like the inner ear that we're doing actually hearing in the cochlea, very small part of the body with very small blood vessels. And so because insulin resistance not only creates energy deficits in the cells of complex signal processing, but also causes constriction of blood vessels and lack of proper dilation of blood vessels, not to mention capillary essentially atherosclerosis, blockages of vessels, you get decreased blood flow to those very sensitive areas. And so it makes so much sense. But, hearing loss is very difficult. And I think for most people, if there's anything they could do to help prevent it or slow it down, they would, but we're not even giving people this information because the way we practice is so fragmented. So it's just not an ENT doctor's even in their radar to think about blood sugar. So that's really what this book is about, is to help people to start seeing those connections.
Yeah. So good. I remember talking to Ben Bickman because he's actually in the lab, like looking at hippocampal tissue, right? And finding insulin resistance there. And at the same time, there's hyperinsulinemia, right? So there's so much insulin in the system because as you progress more and more, your pancreas needs to pump out more and more insulin. So, and then as of course, any molecule in excess is your body's going to develop a resistance to that molecule. I know that from alcohol and coffee, but also true with insulin. And then the double-edged sword there is that your brain stops being able to use glucose for energy, but in the presence of all this insulin, the body's also not being able to make ketones or break down, triglycerides into fatty acids for energy use. So then you're in this constant energy deficit. And it is, and then of course, like the presentations of it are just awful.
Yeah.
There's so much suffering associated with it. So
you bring up such a good point, which is like, I think a lot of people get confused. They're like, we're eating more than ever, but we have less energy than ever. But if you were eating more energy substrates, why wouldn't you be able to just make more energy? And it's exactly what you talked about, which is that when we overload a system with too much raw material to process, it's not like you just get more output. You overwhelm the system and it ends up gumming up and breaking. And so it's like this, I always think about like the Starling curve. It's like this curve where it's basically like, I'm speaking to someone who thinks a lot about hormetic stressors, but like the more you stress a system, the more positive output you will get. You want to get to that sweet spot of stressing and challenging to get maximal output. But when you go too far, you will start to get rapidly decreasing output. This is burnout. This is overwhelm. This is mitochondrial dysfunction. You can't expect really anything in nature that is generative to be able to take infinite demand. It's going to say no. And that's essentially what's happening as we're overloading the body with too much stuff and then simultaneously damaging the machine that processes that stuff with all the other aspects of our environment.
Yeah. So just to shift gears slightly, I read a New York Times article over the weekend that had population projections going forward over the next 20, 50, 100 years. And obviously this somewhat depends on our immigration policy. But if we were to have a very kind of restrictive immigration policy, we're going to see really tremendous population decline in the United States. And a lot of that is due to this infertility crisis, right? So, I'm reading about like sperm counts diminishing, for example. What is the relationship between metabolic health and fertility issues? Can you untangle that? Because at first, you wouldn't necessarily instinctively connect them.
Yeah. I would say very simply that our fertility crisis, which absolutely is a crisis, is fundamentally a mitochondrial crisis. And we have to treat it as such. What's happening on the female side is that the leading cause of infertility in the United States is polycystic ovarian syndrome. And fundamentally, what's happening with polycystic ovarian syndrome is that excess insulin stimulation of the ovarian theca cells is causing these cells to make more testosterone than they are meant to. So this stimulation of insulin is disturbing the delicate balance between testosterone, estrogen, and progesterone. And because of that, it impacts our menstrual cycle and our ovulation. And so we're getting, this issue with essentially infertility. And then, of course, that excess testosterone and androgen hormones in the body are creating many of the other symptoms of polycystic ovarian syndrome. And then in men, the reports are suggesting that sperm count is down 50% since the 1970s. And this is so tied in with insulin resistance and mitochondria as well, because one of the sequelae of insulin resistance, insulin is a pro-growth anabolic hormone, and it's going to block essentially the breakdown of fat for energy. And so as insulin is high, which as we've talked about is really a result of this internal cellular mitochondrial problem, the insulin is driving men to lay down fat, especially around their abdomen. And that abdominal fat, that visceral fat, is actually an endocrine. It's a hormonal secreting organ that literally is converting testosterone to estrogen. So I love what Ben Bickman says, which is that fat along the midline of a man is basically acting like a giant ovary. So you've got both the...
That's enough to get you to stop drinking beer,
truly,
right there.
Yeah, exactly. And to start thinking about your mitochondria. So it's like in women, both due to insulin resistance, we're getting too much testosterone in men. We're getting too much testosterone in women, and we're getting too much testosterone being converted to estrogen in men. And that's, of course, going to impact, low testosterone is going to impact spermatogenesis. But then on the other side with men, one of the reasons we have the mitochondrial crisis is because of all the chemicals in our food, water, air, homes, personal care products. There's been 80,000 plus synthetic chemicals that have entered our world in the past 100 years through industrial processes, most of which are totally unregulated for safety, none of which have been tested synergistically for safety. Like, we've never actually looked at the 100 of chemicals we put on our body every day and see how those work together to hurt us, and many of which are direct mitochondrial disruptors. So there's a thought as well that a lot of these chemicals that are hurting our mitochondria specifically are also in men causing problems with how they create sperm. So very much it's all tied together. And unfortunately, it goes farther than just getting pregnant. Fertility or pregnancy outcomes are also worse for women who do get pregnant, but who have metabolic dysfunction throughout their pregnancy. So we see problems with placental dysfunction. The placenta is literally an organ that creates itself for just this purpose of pregnancy. Very energy intensive organ. It's doing so much work every day throughout pregnancy, needs energy to function properly. So people with insulin resistance and metabolic dysfunction have much higher rates of placental dysfunction, which of course impacts fetal development. So miscarriage rates are higher with metabolic dysfunction. Placental dysfunction is higher in people with metabolic dysfunction, and childhood health problems are higher in people with metabolic dysfunction. So it's super tied together, and it's literally not at all how we're treating the fertility crisis. We're actually just, the conversation is so much around expanding access to assisted reproductive technology, which are going up, like those procedures like IVF are going up astronomically. I think we did over 200,000 last year in the United States. So we're driving the conversation towards that reaction to the problem rather than to the root of the problem, which is such a disservice to people, because we essentially make, getting pregnant the absolute peak of sort of success, as opposed to making, really healthy healing of the fertility issues the way we measure the success. So yeah.
No, in that same New York Times article I was reading about the infant mortality rate, it was just staggering. And just also the child mortality rate in general. And we tend to think about insulin resistance and, adult onset diabetes as something that impacts people in middle age and beyond. but that's not true at all. This is absolutely impacting, our young people. And, I know that, we've talked about, I think in prior conversations about this enzyme aromatase inside of fat cells that convert testosterone to estrogen. And in men, that also leads to all these secondary sexual characteristics. So I've often joked about my man boobs and things like that. But it is ironic that oftentimes it's like these big, burly dudes with big, bellies who kind of are like these kind of tough bully guys. They actually have the lowest rates of testosterone. And so, this is just another reason why we need to go upstream and look at our core metabolic function and our mitochondrial functionality. You also mentioned that insulin is growth oriented, essentially anabolic hormone. It's also very tied to IGF-1. And so how does that play into some of the other big chronic diseases? Like I'm thinking about we could unpack this probably for 3 or 4 hours, but like cancer or heart disease, et cetera.
Yeah. Well, when we think about something like heart disease, which is the top killer in the United States for both men and women, the metabolic links are so interesting and so multidimensional. I think one that is really interesting is around blood pressure. So high blood pressure is one of the leading risk factors for heart disease. And when we think about blood pressure being high, it's an issue in part with the blood vessels not being able to dilate effectively. And that creates so much strain for the heart to basically pump against these stiffer arteries that aren't elastic and dilating. And one of the things that impairs the process of blood vessel dilation is high insulin levels. High insulin levels and insulin resistance on several levels from the brain to the actual blood vessel lining can impair the process of creating nitric oxide, which is the chemical that floats around that basically tells our blood vessels to dilate. So insulin is directly impairing the synthesis and activity of nitric oxide. And then on the other angle, when we think about heart blockages, like more plaque buildup, we know that hyperglycemia, high blood sugar is pro-inflammatory. So you're going to get more sort of activation of these sticky inflammatory cells that can kind of gum up the system and contribute to some of these heart blockages. And inflammation in the vessel walls just creates this fertile landscape for things like cholesterol and other things floating through the blood to create these blockages. And so it's like this 1-2 punch between high blood sugar and high insulin blocking the dilation, creating blockages. And not to mention also high blood sugar is glycating the blood vessel wall, so literally sticking, and that further increases inflammation. So all of this, the way we're approaching it is like, oh, okay, well, obviously we've got to just lower the cholesterol because that's sticking to the blood vessel walls and creating the blockages. Or, oh, we've got to give, an ACE inhibitor or other medications for blood pressure that force the body to relax its blood vessels. But what, of course, we're calling for, what we're talking about is like, what if we went upstream and looked at like, why is the insulin high? Why is the blood sugar high? It leads us straight back to the mitochondria. And when we can free up that capacity, it's really the root and the trunk of this whole tree. So that's sort of the very simple picture of the heart disease.
Yeah, I think there's also some mechanism related to aldosterone, essentially, that there is sort of a dysregulation of processing of essentially salt in the body that then retains more liquid or more water, and then puts more pressure on the actual vessel itself, and then it thickens over time, et cetera. So we need to focus on keeping insulin levels balanced, essentially.
Yeah.
And we are designed to do that. I mean, you were talking about, that titration of the liver, just to keep like the exact right amount of glucose in the bloodstream. I mean, we are engineered for that. We just really need to swim with nature's current
Yeah.
here.
Yeah, absolutely. Yeah. Yeah. I mean, the framework that helps me so much to just think about like what's happening with all of this is that like all these diseases, all these symptoms, like they are simply just our body's way of telling us that either its needs are not getting met or it's being overburdened with something it can't handle. And we started this conversation by talking about like really how can so many different diseases be related to a very core root cause. And, you know, I really like to think about the body with such an intense sense of compassion, because when we reframe understanding symptoms as a way our body is speaking to us about having its needs not being met or being overburdened, I think it really helps us reframe how we approach it. Like we're not fighting the body, we need to support the body to do its best work. Like there's literally, I can't even think of another more miraculous thing invented, you know, literally self-assembling in nature than the body. And it when it gets what it needs and isn't overburdened, it will happily generate for us the most unimaginably beautiful experience of this one lifetime that we have. But when it isn't getting what it needs or when it's overburdened, like it will break down. And so I think of the cells, like all of these 40 trillion cells and over 100 trillion bacterial cells inside my body and my microbiome, is like me as the self, like Casey, the self is the mother of these 140 trillion cells. Like this consciousness is the mother. And so the cells can't speak to me, and they don't have mouths and they don't have arms. They can't go somewhere or talk to me. So they're going to speak to me in the only way they can, which is symptoms and diseases. And just like an infant can't speak to us in words, they're going to cry. And our symptoms are the cry. And just the empowering message is that just like with a baby, when it's crying, you run through the checklist of what it might need. Is it hot? Is it cold? Does it need to sleep? Does it need milk? Like it's a very short check. Oh, does it need a diaper change? Yeah. Is it hot? Is it cold? Does it need a diaper change? Does it need milk? Does it need to sleep? Well, we know enough about cellular biology. This is the good part of the time we're living in, to know what the cells need, to know what the cells need to work properly. So we just have to run through our checklist of the things we can do. And that checklist literally is food, sleep, movement, stress management, toxins, light, and temperature. Like that's what we can control. And so we have to learn what aspects of our environment and lifestyle have a clear evidence-based relationship with impacting the mitochondria, where we in our life across those different vectors are falling short, be really honest about it, and then work to fix it. And so many people who have healed, I think, can say that it can, in many cases, be that simple, that when we start with compassion to meet the needs of the cells or not overburden them, a lot of the symptoms of diseases will melt away. And it's just a very different perspective than what I learned in medical school.
Yeah. And this is where there's tremendous agency, and where we should feel very optimistic, because we're very familiar with downward spirals. We just unpacked quite a few: infertility, early cardiovascular disease, diabetes, et cetera. We're not as familiar with upward spirals, but they happen in the body. I will say from firsthand experience, I've experienced one myself, of an upward spiral when you can be honest, like you say, about the things that will support the cell, and you are able to reify those conditions in your life. You can experience those upward spirals. And so this has been an amazing conversation, and I'm excited to jump into the next one, where we can actually examine some of the evolutionary mismatches and then how we can meet those mismatches to upgrade our functionality. So thanks so much, Casey.
Thanks, Jeff.
Hey, thanks a lot for watching. If you enjoyed this video, then I think you'll love this one too.